Alzheimer's and other dementias are underdiagnosed and often diagnosed late, particularly among women, Black people, and Latinos. At the same time, the latest treatments are most effective in the early course of the disease. This panel will explore how cutting-edge innovations, such as blood tests, digital cognitive assessments, and AI, can enhance detection and diagnosis rates for everyone, and answer the question, how can we ensure the advent of new diagnostic and AI-based tools for Alzheimer's disease address rather than widen those disparities? Susan Dentzer, CEO of America's Physician Group, kicks off our conversation.
Hello, and welcome to this panel discussion on Alzheimer's detection and diagnosis, embracing innovative technologies and advancing equity. I'm Susan Dentzer, President and Chief Executive Officer of America's Physician Groups, and very delighted to be the moderator of this excellent panel discussion today. As you've heard, Alzheimer's and other dementias are underdiagnosed, often diagnosed late, especially among women, Blacks, and Latinos. And at the same time, the latest treatments are most effective early in the course of disease. So this panel will explore how the cutting-edge innovations that we'll be talking about can improve detection and diagnosis rates for everyone. Some of those innovations that we'll be discussing include blood-based biomarker tests, so-called digital cognitive assessments, and the use of AI to guide appropriate care pathways. And in discussing them, as you've heard, we hope to address a critical question: how to ensure that new diagnostic and AI-based tools for Alzheimer's disease address disparities rather than widening them. I'm most pleased today to be joined by three distinguished panelists, and I'll introduce them briefly now. First, we're happy to be joined by Dustin Hammers, who's a PhD and a board-certified clinical neuropsychologist and associate professor in the Department of Neurology at Indiana University. Among his other distinctions, he's the lead neuropsychologist involved in the longitudinal early onset Alzheimer's disease study, or LEADS, funded by the National Institute on Aging. And he's also the principal investigator on the lifestyle interventions for the treatment of early onset AD disease, Alzheimer's disease study, or LIGHTS, also funded by the NIA and the Alzheimer's Association. His research is focused on characterizing cognitive decline in early onset AD and improving the diagnostic accuracy by evaluating diagnosis of cognitive decline and the presence of advanced Alzheimer's biomarkers. So, Dr. Hammer, welcome. It's wonderful to have you with us.
Thank you very much. It's really nice to be here.
Also, we're very happy to be joined by Chris Monsey, MD. He's the Chief Executive Officer and the co-founder of Viz.ai. That's a leader in AI-powered disease detection and care coordination. Today, the Viz.ai platform has 30 different care pathways, including that of Alzheimer's. And Viz.ai collaborates with 7 of the leading global pharmaceutical and medical device companies to improve access to life-saving treatments. Among the company's greatest distinctions, it was the first AI company to be granted reimbursement from the Centers for Medicare and Medicaid Services via the so-called New Technology Add-on Payment that was introduced in 2020. We'll hear from Dr. Monsey about how AI and workflow solutions can help guide patients to the appropriate treatments and also help dementia specialists and neurology practices in diagnosing and qualifying patients for these new treatments, in addition to preparing patients for treatments and monitoring them appropriately. So, Dr. Monsey, welcome to you.
Thank you.
And finally, we're very happy to be joined by Irving Vega. He's a PhD and an associate professor in the Department of Translational Neuroscience at Michigan State University College of Human Medicine. His research focuses on molecular and biochemical mechanisms behind the accumulation of tau proteins in Alzheimer's disease and related dementias. He's going to be talking about the influence of disparities and ethnic and racial factors on understanding blood biomarkers and Alzheimer's disease. So again, Dr. Vega, welcome to you.
Well, hi, and thank you for having me.
Great to have you here as well. So, Dr. Hammer, we're going to go first to you. You've been leading a program to try to drive better detection and screening of Alzheimer's patients. Tell us about that.
Sure, Susan. One of the things that you mentioned at the very beginning was about the really low rates of detection of either cognitive difficulties or dementia for folks who have it when they go to their doctor. It's actually approximately only 8% of folks who have a condition related to cognitive or thinking difficulty that have been diagnosed. We all would like to think that the annual wellness visit would be able to catch a lot of this, but unfortunately, that's not the case. And we know that in addition to folks not being caught with having cognitive difficulties, those who are identified and are referred on to specialty care tend to be those who are more likely higher educated and Caucasian. So individuals from underrepresented groups very frequently are not making it to work with specialty neurologists or geriatricians. And even the individuals who do happen to make it to work with a specialist, including as a neuropsychologist like myself, we then typically will use cognitive measures that, while we are doing our best to have them be culturally, linguistically appropriate, they have all been developed in their originality to be administered and normed with individuals who are usually not from that underrepresented group. And so as a consequence, individuals who are from underrepresented groups are very likely to either not get a diagnosis or potentially not get the most accurate diagnosis. And so what we wanted to do, myself and I have a number of great colleagues who are working on this project with me at Indiana University, we wanted to bring cognitive assessments as early as possible to the most individuals possible. And we know that primary care is the touch point that is involved with most of our patients. And so what we did was we provided a study where we had 7 different sites within the Indiana University healthcare system, which Indiana University is the largest medical school in the United States. And so those 7 sites have a very large reach and catchment of individuals. So we looked at individuals, anyone who was coming into one of our clinics for any reason whatsoever, and in particular for not a cognitive or thinking concern reason. And if they were over the age of 65, we asked them if they wanted to take part in a brief cognitive screen that used what's called a digital cognitive assessment, or a cognitive or thinking assessment that is conducted. In fact, it was on a tablet. And so for ease of use. And so for those individuals who were interested, we then provided them with the tablet. They were able to take part in the cognitive assessment, and we were able to let them know at that time if they were entirely intact from a memory and thinking standpoint, if they had some questionable difficulty, or if they had some pretty notable difficulty. And for those individuals, then we would follow up with making sure that they were not having issues as a result of hearing loss, for example, or as a result of vision difficulty. And we would follow up with some very brief testing with an administrator to ensure that the information we were getting was accurate. And once those individuals, we were confident with those individuals of that the results were valid, we had the ability to offer them either to work with a provider that we're using the term a brain health navigator, which means this would either be someone who is a registered nurse or someone who is a social worker who was able to then work with them and get them in contact with specialty care services like a neurologist, like a geriatrician. We also had the ability to offer them uh, the option of taking part in getting a blood-based biomarker, a blood test that would look at the levels of amyloid in their brain, which for those on the call who are not familiar, amyloid is one of the two primary drivers of Alzheimer's disease. And so that is what the basics of this study have been, and I'm sure I'll chat a little bit more about it over the next hour or so.
Well, before we go to the others, just a quick follow-up. What have you seen so far? How willing are some of the patients coming in to engage in this? And what have you seen in terms of increasing the levels of diagnosis? As you said earlier, only 8% being diagnosed. What do we know even on a preliminary basis based on your study about how much of an increase we can achieve?
Absolutely. So we, in the year that we have evaluated individuals, we have been able to identify approximately 2,300 folks we were able to administer to approximately 2,300 individuals. And that was around 20%, give or take, of the individuals who would have come into the clinic. And so there were a number of folks who were not interested in getting a cognitive evaluation because, again, they weren't thinking they were having difficulties and they weren't coming in for that. They may have just needed a refill on their blood pressure medication or something like that. So some individuals were not interested, and some providers were also potentially not really interested given the demands that they had and the amount of time that a provider may have to work with a patient. But of those individuals who we were able to assess, we ended up having approximately a rate of 50% of those folks who again, coming in not for a concern of cognitive or memory difficulties, 50% were identified as having questionable or confirmed cognitive difficulty on the cognitive screening measure that we gave. And so just based on those numbers alone, that is a large number of folks who we have been able to provide more information about their cognition or their thinking than they would have had in any other fashion. And certainly than they would have had in waiting 4 months, 6 months for specialty services.
So about a six-fold increase right there in terms of the numbers you've been able to identify, at least to learn more about their level of cognitive impairment.
Absolutely, yes.
Yeah, really extraordinary. Well, thank you for that. This will be an excellent transition, Dr. Vega, to speak with you. As we've said, we have a growing amount of knowledge now about diagnosis via blood biomarkers, and you've been working to apply that knowledge to the special considerations of the Latino and Black communities in particular. So tell us more about that.
Thank you for that introduction and Dr. Hammer's information. To build on what you was said already, imagine having a blood test that you can go to a clinical laboratory and diagnose Alzheimer's disease. So we are very excited that there are molecules in the blood, in the plasma specifically, that are representative of the same molecules that are the pathological hallmarks of Alzheimer's disease, and those can be detected. Their abundance of these molecules can be detected. So in order to go to that gold standard in the diagnosis, we need to better understand how these molecules are actually present in different backgrounds, in particularly comparing white individuals versus Black versus Latinos. The data so far indicates that there are some differences between the different ethnic groups. For example, for Blacks, African Americans, depending on their genetics, the detection of these molecules may be a lower abundance than what is happening in whites. And when we look at the very scarce data that is available for the Latinos, depending on the comorbidities that they have, either diabetes, hypertension, or kidney dysfunction, those factors can also affect the detection of these molecules in the blood. So our goal is actually to further understand how these different factors that are either due to comorbidities, meaning diseases that the individual have, or the contextual factors, the social components that contribute to affect the detection of these molecules in the blood. So another gold standard is, to the point that Dr. Hammer mentioned before, is how early we can detect this. So we are actually looking at individuals that diagnostically have gone into mild cognitive diagnosed as mild cognitive impaired, the early stages before they transition, if they transition to dementia. So looking at those individuals, that would be a gold standard, because we can detect using a blood test early on before they transition to more severe cognitive impairments, and we can intervene in the early stages. But like I said, it's important for us to better understand how these biomarkers are detected depending on the ethnicity of the individuals. So in order to increase participation, which is one of the main problems that we're having, is participation in research. We are implementing this community academic partnership program, where we are going, instead of asking participants to go to our research facilities, we're actually partnering with community organizations and making those members in the community organization part of the research team. So, for example, we are in West Michigan. We are collaborating with the Hispanic Center of West Michigan to contribute to the recruitment and retention of those participants in the research. And then the clinical side, we're actually partnering with a community clinic, a Salta Health, who actually is going to be performing the neurological assessment. We are going to provide neuropsychologists, trained neuropsychologists, to do the neuropsychological testing in Spanish, and also in Spanish, and also doing the blood right there at the community clinic. Because bringing the research into the community and recruiting individuals from those communities to be part of the research team will actually not only increase participation, but bring knowledge on how to assess cognitive impairment within the community, so that, for example, in the community clinic, they can pass that knowledge to the clinical side and actually be able to implement it to the people that visit the clinic. So we're actually amplifying what we can do, not only to increase participation, but bring that knowledge and those resources into the community. Moreover, by training those members of the community, we are actually expanding our diversity and representation in the research team, so that people in the community feel identified with those that are actually reaching out to them to participate, so that we can get information that then we can serve them, and translating research into a service process. Like Dr. Hammer mentioned, sometimes these participants, if they go into the clinic, they have to wait 4-6 months, maybe a year, for a cognitive assessment. By participating in the research, they already have access to cognitive assessment, neurological assessment, and blood work that they will need it to be waiting for that for a long time if they go into just reaching out to a specialist. So translating that research can be of service to the community is another way that we're trying to increase participation and getting knowledge on how these biomarkers can be measured depending on the ethnicity of the different groups, and actually make it more specific and more sensitive, so that at someday we can go to the pharmacy and get that test to measure whether we have a problem in the brain related to the pathology associated with Alzheimer's disease.
Which would be a real advancement in spreading diagnosis and detection of of Alzheimer's and other dementias. I believe, Dr. Vega, you have a phrase. It's usually said research goes from, say, bench to bedside into the clinic, but you talk about bench to community. And this is obviously a stellar illustration of that approach.
Yes, definitely. We should go when we, especially for dementia and Alzheimer type dementia, there is a lot of things we can do to reduce the risk. And as we provide information and reduce the gap between knowledge and practice, we can probably eliminate some of that bedside and just keep the community from the bench to the community.
Great. Well, thank you so much for that. And Dr. Monsi, now we'll go to you and your work on applying the platform that you've developed at VizAI to increase access to Alzheimer's treatments and reduce the variability of treatment, which we know is pervasive across almost all conditions, but certainly it's true in the case of Alzheimer's. So tell us more about that work.
Yeah, and thank you, Dr. Hammer, Dr. Vega. I think Alzheimer's is a disease that we're going to see dramatic improvements on how we manage over the next decade. And we have to decide how quickly we improve things, right? Today, there's about 6.7 million people in the US with Alzheimer's, but Dr. Hammer's work suggests that's dramatically underdiagnosed. Is it double that? Quite possibly. And then Dr. Vega's work to ensure that we have diagnosis through biomarkers is in its infancy. And so we've now got treatments that are starting to show efficacy, which is fantastic. So how do we accelerate that time from bench to community? I think that's what all four of us here are really interested in doing, and I'm sure the audience as well. My background is clinical. I'm a neurosurgeon, and we have a software platform that uses AI to identify disease and organize workflow. What we've heard today is that one of the biggest problems with Alzheimer's is care coordination and managing those patients. In certain university systems, I think Indiana University and Michigan, you're doing a fantastic job. But certainly across the entire population, the management is not consistent. We haven't yet worked out exactly what the best pathway should be, but also how do we standardize that across all communities across the United States? So what our software does is it uses technology to do that. I'll give you an example from another disease that we started working with in 2018. And another neurological disease, ischemic stroke. Strokes are when an artery in the brain is blocked. And unlike Alzheimer's, it's a very acute condition. And so when you have a stroke, every minute, 2 million brain cells are dying. And so these care coordination challenges that we're talking about that we see in Alzheimer's were very acutely felt in stroke. If you didn't get that patient to treatment to remove that clot, the patient would end up in a nursing home. If you did, the patient could walk out of hospital and go back to work. So we developed a AI platform that automatically reads the brain scan, detects the stroke, does measurements of what's called perfusion in the brain to see how serious the stroke is. And within around 60 seconds of that scan having happened, no matter where that patient has had that test, a community setting, a city setting, a center of excellence, or a center that doesn't have any neurological expertise, the system's able to send out an alert to the comprehensive stroke facility where the expert neurologists, neuroradiologists, neurosurgeons can read the imaging and make a decision to transfer and treat. And this software has been proven to reduce time to treatment by over an hour, which, if you think every minute is 2 million brain cells, translates to a big reduction in disability, about a year reduction in disability. Right now, we're working to try and do something similar in Alzheimer's, and it's in the very early stages. We want to work with Center of Excellence like Indiana and Michigan to try and understand what should the standard of care be for these patients. When should that cognitive assessment be performed? How do we detect a signal in that cognitive assessment, even though there's likely to be some variability in how it's administered, depending on the socioeconomic background of the person, as Dr. Hammer said. How do we take signal and say, okay, this patient actually deserves further follow-up with a center of excellence and try and streamline that workflow so those patients can get through to diagnosis and treatment much more effectively. One thing of note of the treatments that we're seeing coming through, they're more effective if the patient is detected early. So just like in stroke, time is brain. Time really matters for these patients. So how do we reduce that time to diagnosis and therefore, if appropriate, treatment? And then how do we reduce the variability in care? So no matter which hospital you show up to, where you live, how much money you have in the bank, or the color of your skin, you're able to get a consistent level of medical care and have a chance to get on the treatments that could improve your life significantly.
So you said your work is at early stages. What literally are you doing now as you try to build the knowledge and expertise? And particularly since this is an AI-based platform, you've got to assemble a lot of data to train your platform into how to make these judgments or offer these perspectives, I guess is a better way to state it. So what exactly are you doing at this point?
Yeah. So the positive news is the technology itself is mature in terms of detecting patterns in data, whether that's a brain scan or a cognitive assessment on the EHR. Right, the technology exists to be able to do that. We're also implemented broadly across the United States. We're in around 2,000 hospitals, where we already have that data flowing. The early stages, though, is working out exactly what you do. Like, what should the triggers be? Because you don't want to flood the clinics with patients who won't benefit from more advanced diagnostic tests and treatment. You want to get that right. So really where we are is working with centers of excellence to identify what should that workflow look like. What should the triggers be for, hey, detect the likelihood of dementia in a cognitive assessment. Maybe there's some sort of follow-up with imaging, detect patterns in the imaging, right? And then using that to trigger, hey, this patient should go to this clinic, this patient should have this follow-on test. We're working out exactly what that should look like.
So at this point, as you said, in the work with these various centers of excellence, you're still essentially gathering the data to try to understand how to train your system to offer these assessments? What exactly, how far along are you really at this point?
Yeah, it's really about, it's not necessarily the training the data, it's understanding what the workflow should look like.
Okay.
So that, we've had billions of images go through our platform, right? That's less of the challenge today. The challenge is, what should step A to B to C to D to E be that the experts agree should become standard of care? And how do you systematize that so it doesn't just work in Indiana University, it works across the board, no matter where that patient's shown up.
And as you have made the point previously, and as we mentioned earlier, there's so much variability in treatment across so many conditions. Are people starting to coalesce around what are the appropriate care pathways for patients?
I think Dr. Hammer's work and Dr. Vega's work is made an amazing start, but I think the answer is not quite yet. They're the experts on this. I think there's a group of physicians who are at the forefront of this, who are creating what that pathway should look like, but there's work to be done. I can see you both nodding, so tell me if that's correct.
Well, terrific. That's a great point at which we can broaden out this conversation again. Dr. Hammer, do you want to take up that question?
Absolutely. No, Dr. Mons, that's the way you phrased that was so good about the knowing what I know about deep learning computer techniques, about AI. It absolutely sounds like the technology you are using and the software you're using to make identifications has a long line of history there, and it's actually the people component of, once we have identified, then how are we going to get people to where they need to go within a very complex system.
Exactly.
And that is exactly one of the aspects that we have been working on. I will say struggling with. I think the entire United States and world is struggling with that as well. That once we've identified someone, then How can we get individuals the care they need as fast as we can? We are having similar questions. It's really a question of bandwidth in terms of when we use a cognitive screen, then how sensitive do we want that to be? Or how specific do we want that to be? If we make things too sensitive, then we have the risk of overloading an already very busy system. And then individuals who are being identified who may or may not have any difficulties are going to have to wait a much longer time than they would have even before. So it's that balance that is really challenging. And we are all, I think, trying to think of more creative ways to come up with this. So one of the main group that was behind a lot of the research that we are working on was the Davos Alzheimer's Collaborative, who had a main flagship program goal of bringing cognitive testing to primary care. And in that group, I mentioned we had the Brain Health Navigator. And that position is someone who has the ability to make sure that patients don't fall between the cracks from the time that they're identified to not only meeting with the specialist for the first time, but going through that process. Because unfortunately, in the larger medical system that we have, there usually is not someone specifically designed for that. The challenge we're having is making sure that processes are in place that individual can be paid, because obviously some hospitals are capable of absorbing the costs for the individual providing that care, and others may not be able to. And so that's something that we have been trying to work with, and with the Davos Alzheimer's Collaborative, I know they are trying to work as well to making sure that these vital pieces of the puzzle, the glue that holds this process together, is able to occur.
I just couldn't agree more with that. I think you can actually think of our technology as trying to be a virtual brain health navigator, because it's connecting the dots between modules of healthcare that are working quite well but are just not connected, and so patients fall between the cracks.
Really extraordinary. So I wanted to just go back a bit to the question of early detection and screening, and the patients in particular. Dr. Hammer, whom you mentioned, you were successfully able to identify and screen, and as remarkable as we said, an 8-fold increase in that detection rate. You said something early on about how many of the tools that are now being used for these cognitive assessments, frankly, are skewed toward more white, more well-educated populations. Is part of the work unskewing those tools, or skewing those tools away from that inherent bias, or not?
Yeah, and it's also one of those things. At the moment that came out of my mouth, I thought, "Wow, I somewhat exaggerated that." But let me explain a little bit more. But you're absolutely right. So cognitive testing cognitive tests have been developed on not on underrepresented groups. And what we as a specialty and as a field over the last 30 years have been attempting to do is to make those tests more generalizable and more appropriate. And so, what we do with cognitive testing, with formal testing that is a little different than just a 10-minute screen, would be look at how people are doing and then compare them to people who are their same age and level of education and other demographic, linguistic factors, those type of things. And so there's a lot of work that's going into making sure that we compare people to the right population group, even though the measures themselves may not have been originally created in that fashion. So I do feel that we as a field have come a long way with that. However, there is the reality that in some sites, for example, me personally, I do not speak Spanish. We have at Indiana University, we happen to have a neuropsychologist that does speak Spanish. But let's say a patient of mine comes in who is Spanish speaking, and my colleague is on vacation, or is for one reason or another is booked out many months. And that individual, I could work with them. I would need to use an interpreter in order to provide that evaluation. And the pros of doing that is it is a better evaluation than no evaluation. However, the con is we are having to have a third party try to literally translate what is being said in order to determine the cognitive capacity of this individual. And so, one of the ways that digital cognitive assessments, if done properly, one of their benefits is that these can be conducted in a way that has been, it can be delivered across a variety of languages to the best attempts that we can to make them across a variety of cultures. There are some theories that no test is completely culture free. The act of having an assessment may be completely foreign to some cultures. But beyond that, if we can get the best we can with reducing the impact of linguistic factors, societal factors, cultural factors, then hopefully we can get a lot closer to getting a purer sense of the person's cognitive abilities.
Very impressive set of achievements that would be indeed. Thank you so much for that. So, Dr. Vega, I wanted to go back to you because you mentioned we're still in the early days of the science here, but that there may be factors related to comorbidities of patients who might present with cognitive issues that may make it less likely that we can detect the relevant blood biomarkers for Alzheimer's. What are the scientific hypotheses for that? If in fact there's some sort of masking that goes on because, as you mentioned, perhaps a patient has hypertension or some other condition, what would mask those blood biomarkers for Alzheimer's?
Yeah, I think for the audience, one way to illustrate, and I go to the community and try to use analogies so that these complex questions can be understood. Imagine you are in a forest and you're trying to look for an apple tree. As more trees are in that forest, the more difficult that finding that apple tree will be. So if we're looking at a peripheral fluid like it's blood, all the conditions that are in the different organs, from the brain to the liver to the kidney to the pancreas in diabetes, inflammation due to a chronic disease, or even a stress, all those molecules are going to be increasing the trees in that forest. Well, we're still trying to find that apple tree in that forest. So how we can be able to, that matrix effects, which is the technical name used to describe that forest, how that matrix, which is the plasma and the complexity of the plasma, we can understand it better so that we can easily target those molecules that represent pathology in the brain. That can help us to differentiate between frontotemporal dementia and Alzheimer's disease. That can help us differentiate dementia with Lewy body from frontotemporal dementia from Alzheimer's disease. So how we can get to that? To the point that Dr. Hammers was mentioned before, in terms of how complex this is, from the neuropsychological point, from the molecular standpoint, it's also very difficult. If you look at our data, and Dr. Mansi mentioned how this is in the infancy, it's because when we look at our data, we can, by a group, we can actually say that this group, this pathology marker, let's say phosphorylated tau, is increasing people with mild cognitive impairment or Alzheimer's disease. And then the normal of cognitive unimpaired individuals, they are here. And statistically, this is definitely different from this. However, you can see individuals in this level that are cognitive unimpaired, and you have individuals with cognitive impairment that are at this level. So they actually overlap. How we can differentiate that at the individual level? I always take this opportunity to push for something, and is that because of the variability and because of our individual uh, propensity or risk that we accumulate to our lives based on our lifestyles, based on our diet, based on our level of education, based on different factors. Each individual will have an X risk to develop cognitive impairment in the future. So it would be great if, as a standard of care, when we are in our 50s or 60s, we do a cognitive assessment or a broad and a blood test and a brain imaging. And next year, when you go to your study, to an annual visit, you do again the blood test and the cognitive assessment. And then in every 5 years, you do a brain imaging. And you accumulate that data so that you become your own norm. You become the same, your range of change is what we're going to dictate whether you are getting into cognitive impairment or not. Accumulating you as a baseline and then seeing your changes throughout the life, instead of trying to see these individuals that we are grouping it because they are white or because they are Latinos or because they are black, and they're using statistics to try to correct for age, education, sex, and all that. Statistics will definitely help us to understand complex data, but it's not. We cannot take a statistic to tell us what the biology is. So I think that in the future, if we can push the system to have, like we do it for men, we have a PSA at 45 or 50 years of age. We start doing the prostate specific antigen test. For females, is mammograms or biopsies, right? It's a standard of care. Why we don't do it to that individual, and then us scientists, we determine what is the range that needs to change in order for that individual to get a diagnosis.
Fascinating. And I guess in the remaining time we have left, we could take what all of you have said and put it together and try to paint a picture of what the world of Alzheimer's detection and treatment could look like a decade from now, as all of these tools and capabilities you've described really take hold and flourish and enable us to create that kind of longitudinal system where we are assessing brain health earlier in the lifespan. And as we know, Alzheimer's and other dementias have a long prodromal period. So it would be really great to start with a baseline earlier in life. And as you said, Dr. Vega, that would be standardized against each individual. And then we would see changes over time and be better able to develop the appropriate prescriptions for treatment, et cetera. And then Dr. Monsi, with regard to the capabilities you're developing, even better steer patients into the right care pathway. So let's imagine for a moment, each of you, I'd like you to take a couple of minutes to describe what that system could look like 10 years from now, if we get to the full fruits of harvesting the tools and technologies you've been describing. So Dr. Hammer, I'll start with you.
Certainly. One piece that we've alluded to, but we really haven't talked very much about, is the context of treatment for Alzheimer's disease right now. So after decades and decades and decades of hard work by the industry trying to identify disease-modifying treatments for Alzheimer's disease, we now have 2 drugs that are capable of reducing and removing amyloid, again, one of the primary players in Alzheimer's disease, reducing that in the brain, actually removing that in the brain. And those studies are showing that it is leading to a reduction in declines of cognitive difficulties for individuals. And so, I mean, with that phrase, what is it? Necessity is the mother of invention. We are living in a time where, instead of just theorizing about if we could identify earlier, then when we do have a treatment that will be able to improve X, Y, or Z. We are living in that exciting time right now. And it makes the need for these early detections with cognitive assessments, and I won't speak for Dr. Vega, but with blood-based biomarkers, and he'll be able to go into more detail. These aspects and the aspects with that and the aspects with AI in the medical record system to identify individuals who should be cognitively screened. All of those pieces together, I think it is absolutely necessary because we now have the tools to provide help. One of the major constraints that we had initially working with primary care about cognitive screening was the idea that, well, even if you identify folks, what can we do? And we heard that time and time again. And I'm very happy to say the more information we're getting about lecanemab, about donanemab, which are the two drugs that are disease-modifying treatments, that fortunately is going a bit by the wayside. And so I'll let others to theorize about their 10-year plan. I just wanted to say that starting out, that this is an exciting time.
And thank you for bringing up that extremely important context about developing and evolving effective treatments. So thank you for that. Okay, so again, just a quick minute or so, Dr. Vega, 10 years from now, how will what you're doing now look different because we will have made further evolution in science and clinical care?
Yeah, in terms of the blood biomarkers and using the analogy that I mentioned before, we hopefully gonna stop looking for just one apple tree, and we're gonna have apple trees and also blueberries and also strawberries, and we're gonna put that data together, and that's gonna give us a picture of what is happening in the brain. And we are actually now working to discover these other trees in that forest that could help us to narrow the diagnosis and increasing the specificity and the sensitivity to get to the diagnosis. And I think a lot of people are working on that, not only us, and we're going to get to that in 10 years. But using that information, I want to emphasize what I would like to see is people incorporating the individualized type of medicine where you get a data point of that individual at 50, at 60, at 70, and you use that data to look at the progression of that individual. That actually would be crucial if we can do it. Why? Because sometimes health insurance say, well, we don't have treatment. Well, as Dr. Hammer said, there are already something available. That's number one. Number two is that the data says, many studies said that we can, if we identify early, we can intervene, and that person, we can delay their progression toward full-blown dementia. Additionally, if we treat individuals at higher risk with hypertension, diabetes, hyperlipidemia, the statistic information says that we can cut almost 50% of the dementia cases in the world. So we have all that information. Let's start using it in an individualized way and in a real prevention so that we can reduce risk of the individuals who develop dementia.
Absolutely. And finally, Dr. Monsi, just about a minute for you to tell us where you think capabilities you're developing now will be in 10 years.
Yeah, I think it's a great question because I think one of the takeaways probably from the panel today is we're in the early days of the clinical development of what we do with Alzheimer's patients. But I will note that 10 years ago, we had the first proper treatment for stroke, FDA cleared. And since then, we've had a big development in the technology, that treats the patients, big development in the technology that gets patients to the right place, and big development in how we treat these patients. You're in a 10x improvement in patients getting treated for stroke. And I think we're going to see the same thing in Alzheimer's. I also want to thank, Biogen, Eli Lilly, the pharma companies who've developed these treatments. They spent billions of dollars. What they've done, most importantly, though, is they've given a ray of hope for this disease and created a catalyst for work around Alzheimer's. And it's evidenced by the people on this panel. In 10 years' time, I think Dr. Hammer's work, yours and others, you will have established best practices for Alzheimer's. I think, Dr. Vega, in 10 years, you will have created biomarkers that can definitively define and potentially monitor the disease. And I think our work at VisAI, I think we will have this AI safety net that picks up this disease no matter where the patient is, and this AI navigator that makes sure they get to the right place. So I want to end with a sentiment of, I feel very optimistic about where we'll be in 5-10 years' time from now.
Well, I think based on what the three of you have said, we have indeed a good deal of reason to be optimistic about these extraordinary advances in detection, screening, treatment, prevention, as you all have said as well, that really will create a very, very different world in the domain of brain health and dementia. So thank you again, all three of you, for delivering such a powerful and important picture of the progress made and much more to come. Thank you again.
A special thank you to Susan and all our panelists for this important discussion. Up next, George Vredenberg has a special conversation with Congressman Tom Cole.